Well, thank you so much for meeting with us again today. I think that putting up as much tick information out there so that people, can do their own homework and find out what's really going on with Lyme and other kind of diseases.
Yep. And why it's so hard to get diagnosed and why it's so hard to treat. We're here with Dr. Simons today, and he's going to help us answer some of those questions. So our first question for you is, there's been a lot of talk lately about Lyme testing being so inaccurate. Some scientists and doctors are saying over 50%. Can you tell us why that is?
Sure. So when we talk about Lyme testing, there's three different things we talk about. One is what's called the ELISA, the enzyme-linked immunosorbent assay, which is our initial screening test, which looks for antibodies against Lyme. The second thing that we look at is what's called a Western blot, which also looks at proteins. And then sometimes we'll do what's called a PCR test to actually look for the germ material. So the ELISA and Western blot really measure this blood protein response, this body's antibody response. And you know what, ladies? It could take weeks for a normal immune system to make enough antibodies that an ELISA or Western blot could actually pick it up. So the most famous example is somebody gets a tick bite, they have a rash, maybe the urgent care center, like, oh, is this a Lyme rash or is this a fungus because you've been at the beach and you're hot and sweaty? They do a Lyme test and it comes out negative because it's way too early. Because again, your body has to make the protein, it has to make the antibody for us to be able to pick that up. The second thing that I think is really interesting, if you go to the Center for Disease Control website, they talk a little bit about this phenomena that if you're given antibiotics early on, that may make your Lyme disease antibody test, ELISA and Western blot, falsely negative going forward. But ladies, I don't think that's as big of a deal, because if someone comes in with a Lyme rash, if somebody comes in with a flu-like symptom or swollen joints over the summer, we would much rather have people prescribe them antibiotics early on and then figure the testing out later. So it's kind of a mixed bag. It's kind of like a good problem to have, so to speak.
When is the best time? Say if you didn't, well, I guess you wouldn't be testing unless you had symptoms, right? You don't just test because you got bit by a tick, correct? Or
yeah, typically you shouldn't. And we definitely do not want people like doing a Lyme disease test like every year. Oh, I want to do my cholesterol, my yearly thyroid, and why don't we do a Lyme disease test just in case as well? So we really don't do Lyme disease testing unless someone has symptoms that we're trying to investigate.
The CDC says you need 5 protein bands to be positive. I was positive for 3 bands and I was having neurological symptoms. But I was denied care. Why is that?
Right. So I think a lot of it is there's a big misconception, even in 2022, on the diagnosis of Lyme disease. And anybody could pause this webinar right now. You pause it, you go to cdc.gov, go to the Lyme section, and it will tell you there that in order to be diagnosed with Lyme disease, you need to have potential exposure to the black-legged tick, that deer tick, and you have to have a certain core number of symptoms which are listed on the CDC website, like headache and swollen joints and numbness and tingling that travels and, visible arthritis and radiculopathy. And way down on the bottom of the page, it says that lab testing is helpful, but not a requirement for diagnosis. So when someone comes to me and they're like, I can't have Lyme disease because my test is negative, I'm like, actually, let's look and see what the CDC says. If you have potential exposure or confirmed exposure to the black-legged tick, and these core list of symptoms, we can use that to diagnose Lyme disease.
Right.
Plus, anybody that's ever known me, everyone knows that I always say that if you're in a tick endemic area and you have, persistent fatigue, a strange arthritis, swollen glands, try $20 of doxycycline and see if it changes your life. That's not necessarily for everybody, but that's an approach that I've commonly found. And in the world of people having issues with insurance coverage, not everybody without insurance can spend $500, $600, $700 on a Lyme test, but they could spend $20 on doxycycline.
Okay.
How do you go about doing that? You have to convince your doctor.
You have to convince your doctor. And
Right.
that's,
more and more people are starting to come around. If you have those core symptoms and you've tried everything and you've ruled out rheumatologic and autoimmune and psychiatric and inflammatory and all these other different types of things, like, let me try, $20, $30 of doxycycline. Maybe it'll change me.
Right. It's amazing.
I think it's important for people to educate themselves and then to try to bring that information to their doctor possibly and say, look, I have 8 out of these 10 symptoms, and can we try this? It's a cheaper way for me to see if I can get better, which then brings me to a lot of times when people start taking antibiotics, they have what's called a Herxheimer reaction, and they think that they're allergic to the antibiotics. And you were the only doctor who told me, watch for the Herxheimer.
Mm-hmm.
Most doctors don't tell people, and so they stop taking the antibiotics. Can you give us a little bit of information on that?
Right. So the Jarisch-Herxheimer reaction is one of those times in medicine where patients may actually feel worse before they feel better. Mm-hmm. And basically the corkscrew kind of spiral-shaped bacteria, syphilis and Lyme disease being the most famous, as they're being disrupted by antibiotics, that toxic kind of reaction can trigger symptoms like more flu, feverish, arthritic symptoms can actually flare up in people. So many medical opinions say that if you take antibiotics and you have this Jarisch-Herxheimer reaction, that's actually more diagnostic of Lyme than $700, $800, $900 worth of blood testing. So yes, I routinely tell patients to look out for that. But another important thing, I've had patients come to me, take medicine, and they're like, wow, I'm feeling so much better, but I'm kind of angry that I didn't get a Herxheimer. I'm like, whoa, listen, that's kind of like an internet legend. Not everybody needs a Herxheimer to get better. Many people just take the medicine and they feel better, and that's what we want. So.
Yeah. When I started the antibiotics originally, and thank goodness I had an EM rash, so it was definitive that it was Lyme disease without a test. Of course, my tests were negative, but they started me on antibiotics, and within 24 hours, I couldn't speak and I couldn't walk. And I was put into the hospital for 5 days and diagnosed with MS, but I didn't have MS. And they stopped the antibiotics, which actually made the bacteria proliferate for longer. And then when I did go back to the doctor saying, I'm still having these problems, the doctor said, oh, you were already treated. We won't treat you again. So that was that's when I started coming to see you. Right. But it took me 10 years to find you.
I was going to make that point before, because Dr. Fried that we spoke to too is like, when you do your own education and you find out this stuff, then you really need to go find a doctor that's going to listen to you. You don't need to debate with every doctor. And if they're not going to be on board with something like that, then you kind of just maybe need to find somebody that is going to really listen to you.
Yeah, that's super important. So,
so there's this phenomena in medicine now called shared decision making, where the patient has an equal part in the decision as the medical office would have. So more and more there's this push towards shared decision making, where if a patient really feels strongly about something and then the prescriber, the doctor, PA, NP feels that it's not going to be harmful, then they might go through with that patient's own idea. I've certainly been interviewing a patient and they suggest something and I'm like, oh, that's actually a good idea. You really seem to know your body very well. So
Right.
shared decision making.
There's
right?
probably a fine line with that because you don't want a patient that's kind of a know-it-all and maybe off a bit, off the subject and pushing for things. But, I try to teach even my children at 11 and 9 when we go to the doctor, they're asking questions about their diet and stuff like that. And the kids look at me and I'm like, no, I'm just your ride. Like I want them to have a comfortable conversation and be able to not have like white coat syndrome and be nervous about it. Doctor, your doctor's here to help you,
Of course.
So, and
that's really important.
That's why like making a list before you go for a medical visit, like what questions you have, what symptoms you have. And people, there are so many good Lyme disease checklists out there. You could print out a symptom list, whether it's the Burascano list, the Horowitz list, the ILADS list, and actually bring that symptom inventory with you, many of them that have good references. And sometimes those symptom lists may trigger something. Oh, I forgot that my left foot is numb overnight. And definitely try to get a printout of any directions or plans that you're leaving the office with.
Or bring somebody with you that has another set of ears, because you kind of get filled with information and sometimes you don't, you leave like, oh, wait, what did he say? I forgot to say that, so.
Especially if you only have 15 or 20 minutes of FaceTime, you want to try to get as much out of it as you can.
I think that's important information. Yeah.
So let's get back to the bacteria itself and why it is such an immune evader. So there are about 1,500 gene sequences of Lyme disease, correct?
Correct.
Okay, so tell us how that could affect the testing.
Right. So we think of both like genetic heterogeneity, like the different strains of Lyme, which could be affected geographically, like the Lyme in California versus Wisconsin versus New York. And then we think of antigen variability in the Borrelia germ itself, which is what we call the outer surface protein, like outer surface protein A, B, and C, for example. So when we're trying to look for a Lyme germ, we have to look for the different strains of Lyme, that genetic effect. And then we also have to consider the outer surface protein, including the effect of antigens, for example. So that gets even deeper when we think about the fact that Lyme germs have been documented to live in a cyst, live in a slurry biofilm, which people think of in the mouth, but you can have biofilm throughout your body, even in what we call an L form, which is like a dormant or like sleeping form. So Lyme can have different genetic makeup. It can have different jackets or sweaters, different outer surface proteins, the antigens, and it can live in different phases and parts of the body. And ladies, I've had some people with every symptom of Lyme disease. I thought they cheated and memorized the CDC website in advance, but every Lyme test was negative, but their knee was like the size of a cantaloupe. And we pull fluid out of the knee and we send that liquid to the lab, and they actually can find Lyme in that swollen joint, for example.
Wow.
And that kind of goes along with this concept of this, cell wall, this outer surface protein, a particular type being what's called peptidoglycan, which is a little like substance, like a debris that forms the cell wall. And we know that through, I believe it was University of Virginia, where they actually had patients with Lyme disease arthritis, and they found peptidoglycan Lyme debris actually in the arthritic joints of people sick for months and even years.
I wish I would have known that before I had 2 knee replacements.
Yeah.
That would have been helpful. It would have been helpful.
Talking about this, and we could go back to the questions, but is there like some like hopeful side? Are you seeing, better tests, better ways to figure out, how to combat this disease.
There's a new test that I forget who just came up with it, but there's a new test that hopefully tests these proteins, correct?
Well, there's actually a lot of new developments. IGeneX on the West Coast has what's called an immunoblot, which looks for a lot more of the antigen variability and genetic heterogeneity. So that's a big improvement. There's another lab called Vibrant Wellness, which is really looking at the heterogeneity, all the different strains of Lyme. Because again, we think of Borrelia burgdorferi, but there's also Borrelia miyamotoi, Borrelia gavzini. So there are many different strains of Borrelia that are out there. And there's some new, I believe it's from Tufts, some newer point of care testing where we'll be able to know at the bedside an early diagnosis of Lyme, but that's not ready for clinical use as of right now.
But it's in the works.
It's in the works.
I'm hopeful.
Right. And again, more and more people are realizing that the Center for Disease Control says you can have symptoms and a tick bite and you can get treated without a blood test. That's where a lot of our energy is going in as these newer and newer types of testings are starting to come out. So yes, this is not a negative podcast we're doing. This is kind of a celebration of all of these new things coming down the line and making sure that everybody that watches this is just more and more aware.
100%. That's our goal behind this.
Yeah. So when they do test, they only test for Borrelia burgdorferi on the Western blot and ELISA, correct?
Well, with the newer testing, like the immunoblot, for example, they are looking for more of the different species. But typically, like on Long Island, if we're looking for Borrelia miyamotoi, which is more of like a relapsing fever, that is a separate test that we will do. But more and more in development, we have these generic Borrelia species panels where we can look for the 3 or 4 different major types of strains. And next time, of course, we'll have to talk about the other monster in the room, all of the different co-infections like rickettsia, Rocky Mountain, Babesia, those different types of things.
Oh, I promise we're having you back. One more thing. Strep and Lyme disease and syphilis are very similar diseases.
Correct.
Why are we treating syphilis for long term and Lyme disease for only 2 weeks? My understanding that if we only treat for 2 weeks, we're killing out the weakest links, but creating a resistant bacteria after those 2 weeks. Since their life cycle is so long, the Lyme bacteria is so, their life cycle is so much longer than, say, strep throat or urinary tract bacteria, that we don't seem to be bracketing the life cycle with the treatment. Can you help explain? And hopefully that'll change soon as well.
Right. Like we know that if you have a confirmed strep throat, you may be given like azithromycin, that famous 5-day like birthday card, and you punch the pills through, which you take for 5 days. But currently 21 to 30 days is the opening, treatment for Lyme disease. So, at least the current standards are triple of what we're treating like a standard strep throat for. Mm-hmm. But that kind of goes back to symptoms and testing, where patients may need a second course, or they may need injection or IV, or even a different antibiotic. I've had people where they've done the 30 days of doxycycline, they don't feel better, and we switch them to amoxicillin, and within 5 days, they're like, wow, this is really doing it for me. Because of that, variability in the different types of species, not doxycycline or your standard medicine may not always work. You might have to rotate between different medications, and that's going to take longer very often than 30 days, for example.
Well, people are very fearful of being on antibiotics.
Of course.
And my question is, you save them for when you need them. right? You don't go on antibiotics for everything, but if you don't be afraid of a 30-day course of antibiotics or even a 3-month course of antibiotics. The problem I feel arises with too many antibiotics in our food, which then is the way that you create that bacteria resistance. Like, so if you're eating healthy and you're eating clean, you should not have a bacteria. You shouldn't have a bacteria resistant in your food. Is that a correct statement?
Well, you have to be very careful when you shop, and the Environmental Working Group on their website has some great info on this. But yes, I mean, I definitely agree with you that agriculture is still one of the bigger abusers of antibiotics in our environment, because we do want to limit prescribing of antibiotics, obviously. But if you come in with an EM rash or a Bell's palsy or a knee the size of a watermelon with the flu, then I would absolutely give you 30 days of antibiotics with the option of a second course if you really need it.
You save, if you could not go on antibiotics for a sinus infection and try to let that ride out and see how it goes. And, you save it for this kind of time. This is the time to use it, in my opinion.
Yes, I agree.
Fantastic.
Yeah. Thank you so much for sharing your brain with us. As always, you're so smart. You're always, explain things so well too, because you're very smart and you're in this little world. And
I had to be.
I like that you break it down for me to understand too. So
Fantastic. So great.
I appreciate that.